Cool. Okay, hi guys. Can you just give me a thumbs up? Hopefully, I think you should be able to hear me. But just let me know in the chat, please. Oh, I realized no one can actually use the chat. So let me enable that. Okay, cool. So hopefully that's working now. If you guys can just type in the chat to confirm. Great. Okay, let's kick off. So my name is Shoaib, and I'm the course organizer for BitePACES, and we've been running these webinars for quite a while now. Kind of run them almost on a weekly or kind of every other weekly basis. And today we have quite an exciting webinar. It's not one we usually do, so it's quite a nice topic where Adeel, who has recently passed his PACES, is going to kind of cover his preparation and the kind of cases that came up in his exam. So I think that'll be quite useful because probably the most frequently asked question I get is what came up in this exam center. Now I don't think that's like I don't like to give out information anymore just because I think sometimes it can bias people in the wrong direction, but it is useful to know the general sorts of cases that come up. Um, Now, having said that, I'm sure you guys know by now we run an in-person course in London at King's College, so that's at London Bridge. We have our flagship one-day course, and we also have a comprehensive course. It was formerly 4 days, but I'm just trying out a 3-day course this time round. And that's for a number of reasons, but I know people are kind of tight on study budgets and available time. So the 3-day runs from Friday, Saturday, and Sunday, and it's just a bit easier to get the leave. It's more affordable, and we still cover every single station within the course of the 3 days. So I think that's quite an efficient way of running things. These courses we've previously sold out and been oversubscribed for our past two course dates. So please do make sure you book soon if you are interested in coming. I think the thing that stands out about our course is that we have you in pairs. So you're going around in small groups. You're not sort of in large groups, and you do really get a lot of interaction with the patients. But yeah, I'm not going to speak too much about that. Basically, you can find us at www.bitepaces.com, and you can join the WhatsApp group for our remaining webinars. Yeah, discount code, you get £20 off if you use this discount code here. Some feedback. Basically, we're rated quite well on Google with 4.8 out of 5 stars after about 50 reviews. And yeah, please join our WhatsApp group. That's where we have our upcoming webinars. We've got one on cardiology. We've had one on clinical consultation recently. And I think we have one on presentation and Viva technique coming up towards the end of March. But without further ado, Adeel, I'm going to hand over to you and I'm going to let you take it away.
Thanks, Shoaib. Hello, everyone. My name's Adeel. I was in your position just maybe a few months ago. I did my Bike Paces course in September, and I had my first attempt at Paces on November the 2nd, and then my second attempt on the 2nd of February. And I just found out a couple of weeks ago that I've passed the exam. And Shoaib wanted to just invite me over, and so I can talk to you about my experience with the exam. So I'm just going to start off by sharing that slide. Mhm. One second, here we are. I think that looks good. So yeah, I'm an IMT1 at St. James's Hospital in Leeds, and managed to do my paces quite early on. So before I actually start, can I just ask, is there anyone in the participants with 35 or 36 people who still has their exam in the next month, or are all of you for the next diet? And so you've got one person doing it next month, two of them. Okay. So about, I'd say maybe four or five people still have it in the next few weeks. Just trying to make sense of who I'm talking to, and just so that I can speak with that urgency as well. I think it
Adeel,
would be useful
sorry to
for you.
interrupt you. Adeel,
Yeah.
sorry to interrupt you. I don't know what it is, but like your head is on top of the slides.
Is it? Okay.
Yeah, it's like you're projecting over the slides. You know what I
Am I?
mean?
Let me
You
see
can't
what
see it, but that's how it's appearing to me. I don't know if it's appearing to everyone else like that.
how does it look like now?
Yeah, there, perfect.
Is that better? Sorry, I think
Yeah,
I must have done the other
yeah,
the
I
other
do that.
one.
Don't
Yeah.
worry. But yeah, so sorry, it should look quite funny. I'll let you crack on.
Yeah, thanks. So it's good that the ones who still have their exam left in the next few weeks have also joined, because I can tell you exactly what you can expect on the day of the exam. And I think that's something that many people don't really talk about or think of. And at least for me, it was just a case of going into this not really sure what to expect. All I knew was I had to come an hour before the exam and just eventually start the exam and finish in 2 hours. But I think hopefully once I'm done with this chat, it might help you calm your nerves, because you'd know what more to expect on like when to arrive, what to do in the next hour before you start. And also I'll share my results and feedback with you too, so that could be useful to look at. So mm, starting off, we've already seen the PACES carousel. We all know what to expect. I'm not going to go into too much detail on how the stations work. But one thing to really consider and think of, if this is your first attempt, is that you have a 5 minute interval before each station. And I'll be honest, when I had my first attempt, I didn't really think too much about those 5 minutes. I just thought I'd have enough time to read through the scenario and then jump in. But what happens is, particularly with station number 3, which is cardio and neuro, you won't have a scenario to read. And also with the station 4, with the abdominal starting off. So you won't have a scenario to look at. You could just be um, relaxed, sitting there for 5 minutes. It'll be more of a break for you. Um, so starting off, you have to arrive at your given time. I'm sure some of you have already received your admission papers. You have to bring that with you, along with an identity card, anything that you can document your information. Uh, Funny story about this. So I had someone who was giving the exam on in my center, and they came late to the center because they forgot to realize, they didn't actually notice that they had to attend or come to the outpatient center of the hospital, and instead they turned up to the hospital main gate and tried to figure out where the actual outpatient department was, when it was actually 10 minutes away from the actual hospital. So make sure you read your admission document and see where exactly you need to be, and double check that on Google Maps, because otherwise that'll just add to the stress. And I remember that poor chap came in around half an hour late, completely panicking. But of course, we had still had enough time to just sort of let him sit down and um, prep for the exam. So once you come in, the first thing you have to do is register. You sign your name into a whatever they have, their admitting sheet. And then you are sat down in a room with 4 other candidates. This is a nice time just to have a chat with the other 4, calm your nerves and speak to them about what they're expecting. Some of them might be giving it for the second time. So listen to what they have to say about how their first attempt went. And so this is the other bit that I didn't realize until I went in, is that when you're sitting in the waiting room and you still have an hour left, the reason why they actually call you in a full hour or so before the exam is because they have to hand you these clipboards with your mark sheets. And then you have to fill out those mark sheets with your candidate number, the examination number, and the center number. And you have to do that 16 times. And it's one of those sheets where you sort of circle, or sorry, draw over a box each time, like one of those OCR sheets, the old standard ones. So you have to do that 16 times on your mark sheet, and that actually takes a little over 20 minutes. Um, and the interesting thing here is that's actually when they give you the clipboard, they'll tell you what station you're starting on, or the station you'll be starting on will be on the top. So I started with station number 3, and I knew that I will be starting with cardio and neuro. Also because the sheet itself will tell you that this is station 3 cardiovascular, station 3 neurology. So another thing to remember is you don't actually need to memorize which station number coincides with what station. It'll tell you on the mark sheet, and they will give you the mark sheet according to the order that you will do your exam. So I'm not really sure what's the best case scenario, whether the station starting on 3 or station starting on station 5. In my case, I started on station 3 on both attempts. So I thought it was good to get over with the tough parts first. And you also have the lead organizer come in near the end of the 1 hour just to welcome you and just tell you some nice soothing words about how everything in the exam is what you prepared for. Nothing's coming out of what you've been told to prepare. And that also, I think, helps calm your nerves. So now I'll just go into the actual stations I had. I started off with station 3 cardiology, and I had this prompt, and I'll just start listing the findings in the same chronological order of my examination. So on inspection, I noticed this lady had a midline sternotomy scar, and there was also a small scar in the left intraclavicular area. And I didn't notice any signs of cyanosis or clubbing or any features of infective endocarditis. And that already gave me an idea of what to expect with the station. Moving on with the examination part, the pulse was regular. It was not collapsing. JVP was normal. There was no pallor or central cyanosis. And then I'll come to the heart sounds in a second, but just to let you know, the back and legs just showed some mild pitting edema to the mid-shins. Now, this is what I found with the auscultation. So I usually start off with the aortic area first, just because I'm a creature of habit. I like to do it the same way each time. So I started out with the aortic area and I heard a moderate systolic murmur. Then I listened to the pulmonic area and I didn't hear any murmurs. Similarly, going down, no murmur there. And I thought there was a very mild systolic murmur at the apex as well. And then I went on to listen to the radiations, and I actually heard some radiation going towards the carotid. So that was really the giveaway. And there was no radiation in the axilla. One thing here that I remembered during the exam was that sometimes with aortic AS murmurs, you can hear the murmur even down to the apex, but it's not actually mitral. It's not really a mitral egress murmur. It's more likely to be an AS murmur because you've also got radiation going to the carotids. And of course, now here's the tricky part. You finish cardiology station, you've spoken to the examiner, you've given your presentation, they've asked you the questions, and you hear a knock outside the door. That knock is actually the end of your 6 minutes of cardiology and the beginning of your next 6 minutes with neurology. So unfortunately, you're already, since as soon as they give you the knock, you're losing time for your neurology station. And that means you still have to walk with the examiners, depending on what sort of room they have or what setup they have. You'd have to walk out that door, go into another room, enter that room, look at the prompt for neurology, and then examine the patient. And I honestly think that takes around 20 seconds out of your 6 minute. So just be wary of that and expect that when you're going in. So maybe just try and nail your neuro exams in 5 minutes and 30 seconds. So this is what I had in my neurology prompt, that there was a man with double vision, and I was asked to examine the cranial nerves. Cranial nerve 1 was normal. Again, nothing on cranial nerve 2 or the optic nerve. Then cranial nerve 3, 4, 6, when I was doing the haste test for the oculomotor, the patient mentioned, he literally told me that he's got some double vision when he's looking to the left, which is worse when looking down and left. And then after that, all the other cranial nerves were normal. And because that's the only finding I had in the whole cranial nerve exam, I had a lot of time left even after I finished. So I just went back to test the eyes again, and I asked about pain. And I even checked for any scars on the head for any surgeries. And just to note, when I was asking about pain, I just asked when he was moving his eyes whether there was pain there, because you can't actually ask too many questions apart from just like, in this case, just the one question here about pain or double vision. Um, just from this, can anyone give up some guesses as to what the diagnosis could be? Oh, I don't know how to look at the chat itself. One second. Ooh. Oh, anyone, any diagnosis at all for this? I guess not. That's okay. Going back to the slideshow though. Oculomotor abducens nerve palsy. That's the left abducens nerve. So those were my guesses too, and I said, okay, so it's something with the eyes. It might be oculomotor, it might be abducens. Uh, so what it actually was a trochlear nerve palsy, and I was rubbish in any of the eye palsies whatsoever, because Um, all I knew was that I could try and figure out where they've got double vision and then try to work out if it's one side, if it's abducens or trochlea. The one hint that they were giving me was that it was worse when they were looking left and down. This is what I got in my feedback, and it says clearly that I did not test the eyes separately, and I also did not offer fundoscopy because I was panicking. Um, and they felt that my assessment for eye movements was very cursory, and I did not really define the area of diplopia. So what this feedback is showing me, that I actually got 0 marks for physical examination here, and 0 marks for identifying physical signs, because I also missed out the restricted adduction of the left eye. Um, So what you're supposed to do with cranial nerves, at least with the oculomotor, trochlear, or abducens nerve palsies, is also examine or test the eyes separately. This is not something that I was used to doing in my practice for bases, and didn't even know that I need to test the eyes separately. So when I was presenting my case, I just said this could be oculomotor, trochlear, or abducens, and they tried to just push me towards diagnosis. And I eventually went to say that it's likely going to be abducens or trochlear, because there's no pain, and also the I think the light reflex was normal. So it's quite difficult. This station was. Moving on to the next station 4. This was a communication station. I'll just give you a minute to actually read what was on the prompt. So essentially, it was about someone who's had a new diagnosis of GBS. And thankfully, they told me the diagnosis was GBS, and all I was supposed to do is explain the diagnosis to the patient, include the next steps in management, and address their concerns. So I tend to follow the spikes protocol. You might have a different protocol in your head, um, but just make sure that you have a protocol in mind, just so you don't end up missing things. So after I explained the diagnosis as best I could, the patient had some questions, and basically it was about whether it could be multiple sclerosis. Will he get better? Could he go home after the IVIG? Now, you could imagine the first question and the second question is probably easy to answer, which is no and yes. But going home after the IVIG, I wasn't entirely sure what the timeline is for or the course of disease is for someone with GBS. So I wasn't very confident in saying that, oh, it's going to be days or weeks or months. So instead, I just said something like, we'll just start you on the IVIG and see how you go. You've got a neurology unit over there, and I'm sure the doctors there will just keep an eye on your recovery. And because of that, I got a borderline, sorry, borderline result for communications because I couldn't give clear information about the course of the disease. And then for clinical judgment, again, I got borderline because I forgot to mention the need for assessing vital capacity. In my head, I thought it might be for someone who's very symptomatic. But I think, again, in GBS, once you've got a case of GBS, it's important to mention that it can also affect your lungs, and therefore we need to monitor the vital capacity. And then this was the abdominal station here. The gentleman presents with tiredness. Please perform an abdominal exam. So this is the first thing that I saw in the abdominal station was this guy had a stoma. And when I looked inside the stoma, I think what I saw was type 6 stool. Of course, remember to have a look inside the stoma to see your contents and just look around the stoma for any inflammation and just have a system to how you examine a stoma back too. I think there were a couple scars that I saw. One was a midline laparotomy and another one just next to it. So presumably he's had multiple abdominal surgeries. And then I also saw a right diagonal inguinal scar, which I'm sure you all would know could actually make this into a kidney or a renal station. But I wasn't sure entirely because in my head, I thought it could also just be the lining of his trousers making that scar on him because it was just really that low. So I thought I'll just skip it for now. Um, Moving on to the arms and neck, there was nothing there, no fistulas, no lines. And then in the abdomen, no signs either, no organomegaly. And I double checked for any masses underneath the scar. There was nothing there. And I got the 1 minute warning before I got to assessing ascites. And I think personally, I think I didn't finish that station soon enough. Mainly because I felt when I've been practicing for the abdominal station and paces, I got more and more comfortable with catching renal pathologies, and I didn't spend too much time on things like IVD or what to say when someone's got a stoma, basically. And that's why I got the feedback that I didn't complete the examination here. This was actually a case of Crohn's disease, and the interesting thing about this station was that when they asked me to present the case, I told them my positive findings and I told them my differentials. Instead of going down the route of Crohn's disease or IBD, they took it to a different route and said, how would you manage this case of someone presenting with a high output stoma? And then they asked me about the electrolyte disturbances that are commonly seen in high output stomas. And again, even though I was able to give the answers, it was still not quite what I was expecting. I thought it would just usually be about IBD itself and the management of IBD, but in this case, it wasn't. So apparently that can also happen on a PACES exam. Then this was my 20-minute consultation, the first one that I had. So I'll let you read this. 85-year-old gentleman presenting with weight loss and loss of appetite in the last 6 months. Review the patient and address his concerns, outlining the next steps in management. Now, if you were there in my position and you read this in the prompt, what sort of differentials would you consider? Could anyone try and give us some differentials? Malignancy, exactly. So as soon as I read the words weight loss, loss of appetite, 6 month, 85-year-old, I just immediately went malignancy. And that's the only thing that my head was buzzing with. And I thought this should be an easy scenario where I just ask them questions about their weight and their appetite and family history, that sort of stuff. Yeah, so let's see what happened. So you have 20 minutes, and again, that's a lot of time, 20 minutes. I had more than enough time left even at the end of my consultation station. So history of presenting complaints, there was nothing interesting. On past medical history, this guy had rheumatoid arthritis and high blood pressure. Medications included rituximab, and he mentioned that he's previously been on methotrexate, but he was switched to rituximab now. And then in the family history, lo and behold, he mentions that his mum died from some kind of cancer. Social history, he was an ex-smoker, doesn't drink alcohol, nothing special about his occupation. And then on examination, as I expected, I saw some ulnar deviation, so some metacarpophalangeal joint swelling. Lymph nodes were normal, eyes were okay. I heard some crackles on the right side of his chest. And that's all the information I had to go on for him. And then when I talked to him about um, his findings, his first question was, could this be cancer? And the way that I'm sure that you all know how to deal with a possible cancer diagnosis in PACEs is that you can't say no, but you also can't say definitely yes. So you talk about the investigation that this person might need before we confirm this. And so yeah, the usual bits, blood tests, imaging, and then MDT, and then we'll get back to him to confirm what this could be. Um, this is what I got from my feedback for this station. Now, I got a borderline for identifying physical signs. Because apparently I thought the crackers were right-sided, but apparently this examiner said it was clearly bilateral. To me, it wasn't, but apparently it was. So that can happen sometimes in the exam where you end up just listening. And so obviously you can only tell them what you hear. And then in clinical communication skills, this was the very annoying part, which I still hate myself for doing this, is that I forgot to ask about infective symptoms. Now, like you guys mentioned, that this was probably more likely a malignancy case. I had the same thing in mind as well. So I never, for some reason, never really got to talking about infective symptoms or asking him about any symptom of infection. Maybe it's because when I was there, I was thinking a lot more on the sorry, thinking a lot more about the malignancy rather than trying to rule out other things. And that's why I think with consultations, what's really important and this is what I got right the second time round is that I had a cluster of questions in my head for each system. And I also had a cluster of questions in my head for some of the main presenting findings. So you could maybe just sit down one day and just make some questions on a list and just go through them, make sure that you don't miss anything. I think this part, making a cluster of questions in your head was probably the one thing that actually helped me pass the second time round. And communication stations, you're a resident doctor at the general medical ward. I let you read this for a minute. If you have any questions in the middle, just raise your hand and I can always take the questions in the middle. Don't mind. Yeah, so from what I remember, I think this was basically a lady. Was it about a lady? The wife, right? Yeah. The wife on the ward wants to talk to you because she feels that her husband shouldn't be ready to come home yet. Now, just reading the prompt here, I don't think it's very clear why the wife isn't happy. When I was reading the prompt, I thought, oh, maybe it's the fact that we've not given her a medical update. So when I went into it thinking I just need to uh give his wife a update about him, and then she should be fine. But things were actually slightly different. So as I went in, the first thing she told me was that she couldn't believe that he's coming home, and she was surprised that it's only been a couple of days. How come he's well enough already? And then she started getting more and more emotional and started practically begging me to keep him in the hospital for a few more weeks. So this is how my station started. So I thought, okay, let's try and get some background on why she's actually so worried about this. And when I did ask her about her husband, this is when she mentions that my husband has Alzheimer's for so many years. And that was the first um, spark in my head that, could it be the fact that she's not being able to take care of him at home? And it was that case. So essentially, it was just her complaining that she needs some help at home. And then from that point on, you can imagine it was quite straightforward, where you'll talk about having occupational therapy and physiotherapy and making sure that he's got carers at home and whatever help they need. So yeah, I think the communication stations on both my exam were very straightforward. And then there was the respiratory station, someone presenting with shortness of breath. So on inspection, I didn't find anything on bedside, usually looking for inhalers and that kind of stuff. I noticed some clear clubbings on the hands, and the patient was very cachectic, clearly. And I didn't find any scars around their chest, front or back. Arms, face, and neck, nothing exciting. And when I went to the back, this is what I found. So bilateral cleft at bases, which I thought were on inspiration, and they were coarse. I've highlighted course with the red because on the day of the exam, I wasn't sure if they were coarse or fine. Now, all of us have done lots of chest auscultations in the past, and we all probably know what the difference is. But sometimes when it's kind of in the middle and you're in your exam, you're just sometimes not sure. And when I listened to the front, again, there were some crackles at the bases, but they were less audible. And there was no edema. So this was a station that I think I messed up on because of my own shortcomings. Um, Identifying physical signs. I got a borderline mark here because I missed the decreased percussion note. So you're probably thinking that you don't actually need to be very good at understanding percussion notes to diagnose a patient. But clearly, as you can see, you still need to be able to identify that physical sign. You might still get the right diagnosis without catching the percussion note, but again, you still get points for physical signs. And if you've missed that in your presentation, then you do lose a mark for that, unfortunately. And in the differentials for this one, I completely messed up and I said this is very likely going to be COPD, even though the patient had clubbing. I have no clue what I was thinking. Maybe I was thinking about the last station or how I messed up neurology or something. But I got the differentials very wrong, and I got 0 marks for the differential diagnosis, and therefore 0 marks for the clinical judgment as well. Any questions so far? I think I'm rushing into this. You can either raise your hand or just leave a message on the chat. I'll give you maybe 10 seconds. Hmm. What was the diagnosis? ILD, clubbing. Yeah, should be straightforward to catch. So I think the reason I messed up is because I thought it was coarse crackles, whereas seems like it was fine instead. Do you usually get this feedback? So when you get your results, sorry, I'm just going to pause in the middle and talk about feedback now for a few seconds. When you, no clubbing, right? Yeah, I think maybe I messed up on saying that there was clubbing when in fact there wasn't any clubbing. I apologize. It's been a little while. So I mentioned clubbing where although the patients didn't have clubbing. So that's how brilliantly I messed up. Um, and even though I mentioned clubbing, I still went with COPD, which makes no sense. So I messed that station pretty much the whole station, which is bad. Going back to the question about feedback, Majid, when you get your results, you can always email so I don't know if you're applying to RCP London or Edinburgh, wherever, you email them back to say that you're requesting feedback. And I think they also have it on the website for MRCP Paces where you can ask for feedback. And I think they're quite useful. Just remember on the day of the exam, you have two examiners. So you have two feedback forms each for each station. Thank you. Moving on to, I think this was my last station. Yeah, station 5 was the consultation. 60-year-old man presenting with progressive shortness of breath in the last few months. We would be grateful if you could review him. So, what do you guys think? Any differentials before we begin? You've read this outside the room. What could you think of just based on the prompt? Heart failure, COPD, congestive cardiac failure, respiratory causes, anemia. Yeah, so exactly. So you're right. Pretty much I had those bells ringing in my head too. So when I went in and I took some history, he mentioned that he was short of breath on exertion, but not on lying flat. That helps you rule out heart failure, possibly. Past medical history, nothing significant. Medication history, nothing. Again, this guy's mom died from some cancer again. And social history, nothing exciting. And this is my station. So the only positive examination finding I had was a murmur that was heard loudest in the apex, radiating through the axilla. And obviously this made me think of mitral recurge. And so these were the questions that this guy had for me. So first of all, it was, what's wrong with me? So you tell them that, oh, you've got a leaky valve, blah, blah, blah. Could your wife have it? Again, it's unlikely that you can catch it from someone else, but I think what I did was I asked him about her symptoms and then he wasn't sure, so I moved on to another question. He asked about the possibility of surgery, and obviously I talked about having an echocardiogram first and then going on to possibility of surgery. Um, so okay, again, pre-anesthetic fitness and all those things are important here. And then he mentions there was this very specific question that his friend had a surgery for his liver through a keyhole. Could his also be done that way? Um, Again, I think I said that if we could think about this possibly, because if it's laparoscopic, we're not expecting this one to be an open heart surgery either. And then, can you still drink with your mates? Probably not. Avoid alcohol at all costs. This was the feedback that I got for this station. Now, yeah, so again, in this one, because I think my mistake was that as soon as I did my examination findings and I found the murmur and I knew what this was, I didn't go back to ask him some further questions, some leading questions, such as palpitations. And as a result, I missed the fact that he has paroxysmal atrial fibrillation. So this was actually also one of the diagnoses that this gentleman had. And therefore, because I missed paroxysmal AF, I also lost a mark in clinical judgment because I couldn't tell them much about what to do with AF. So it's again very important to have a cluster of questions in your head. If someone told me that the first time round, I probably would have passed my exam. Um, so I prepared for it the right way with all the clusters in my head the second time, and I managed to pass it. So again, clusters. Did someone leave a message? Didn't they say it when you asked about past medical history? So, oh, good point, Aruj. So I was complaining about the exact same thing to everyone after my exam. I asked the guy in for your past medical history, do you have any heart conditions? And he says, no. And I mentioned, anything else? Have you got any problems with your lungs, blah, blah, blah. So the usual way I question is, do you have any medical conditions? Anything related to your heart or your lungs or diabetes or high blood pressure? He said, no, 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 no. I didn't specifically ask about palpitations. I didn't specifically ask about a racing heart. And therefore, he didn't mention paroxysmal atrial fibrillation to me. And this is what happens. Funnily enough, I know it sounds quite unfair. On my second exam, I promise you, I had a similar case, not similar. It was a guy who collapsed and he came in and we were in the GP service. And in the second exam, the same thing happened where I asked about his medical history, and he said, "Oh, he's got no problems apart from some high blood pressure." And then I said, "Have you noticed that you've got a racing heart, or sometimes do you feel like your heart's beating a lot faster?" And then he said, "Oh yeah, that happens to me a couple times occasionally." And then you realize, that's paroxysmal AF. And in which center was this? So this first one, the one that you're looking at now, this was at Ashington, which is near Newcastle. Um, I'll be honest, the exam itself was actually quite easy looking back. I think we got some really easy cases in that center over there in Newcastle. But it was just these minute things that were somehow the make it or break it. And unfortunately, that does happen. Were you able to take any notes in with you for the consultation stations? Yes. So for all my consultation stations, I would first of all write down the setting. So when I say the setting, I mean like where am I as the doctor? Am I in the admissions unit? Am I in an outpatients department? Am I in A&E, just to help me understand what the setting is? And then I write down the age of the patient. I write down their presenting complaint, some differentials. Then I quickly write down some questions to ask. And yes, you can take that paper with you. And I was looking at the paper a lot of times in both my exams, and nobody marked me out for that. So use your paper as much as you like. No one's going to stop you. Basically, become a talking systems questionnaire instead of a human doctor. Yeah, so the thing is, if you, again, and I'll be honest, if you have that cluster of questions in your head, you will remember to ask them to the patient. If you don't have a cluster and you just go by your gut feeling and because you think, oh, I know exactly what to ask about chest pain. I've been doing this for the last 4 years. And then just because you forgot to ask about the racing heart, suddenly you lose like 3 or 4 marks in your station. And then that could sometimes be a pass or the difference between a pass or a fail. Um, and did I tell you this? Yeah, I talked about this already tonight. So that was the whole exam. I'm not done yet. I need to also show you my results sheet in a second so you can make a sense of how the domains are individually marked. But before I get to that, this is what I did not expect. First thing is the fact that you will lose 15 seconds or 20 seconds, particularly with the cardio neuro switch. So be prepared. Make sure that you're finishing your neuro exam within 5 minutes, 30 seconds. Make sure you're finishing a normal neuro exam within 5 minutes. Just be absolutely sure that you are not getting 6 minutes in your neuro exam whatsoever. And in my communication stations for both exams, because I had two communication stations each, in all four comm stations, I was finishing well early. Sometimes I was finishing 30, 40 seconds early, and I got full marks for my comms. Someone's writing something. Does the switch happen at 6 or 10? Sorry, I apologize. It does happen at 10. Um, so when you finish the presentation and the examiner finishes asking the questions, and then you're asked to move on to the next station, that's when the clock for the neuro station begins. For the examination station, do you get a reminder or a bell when 6 minutes are up? So you get a reminder or a bell at 5 minutes, letting you know that there's 1 minute left. And then when the 6 minutes are up, the examiners will stop you there and say that, okay, your 6 minutes are up. Can you now present your case? Does that make sense, Safia? Yeah, yeah. And then third point that I did not expect was the order of questioning not having a set pattern. And I say that because, especially with my abdominal station, I was expecting them to ask me about Crohn's disease and, the investigations, the management, blah, 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 steroids, azathioprine or whatever. But instead they took me to a different line of questioning about electrolyte disturbances in high output stomas and diarrhea. So that can also sometimes happen, although I don't think it massively shocks you. But yeah, can happen. And yeah, sometimes you can forget stuff. So I completely just made up the finding of clubbing in the respiratory exam. In another station, I thought it was unilateral crackles when in fact they were bilateral crackles, and that happens. You just have to make sure that you don't make things up. That's one thing. Second advice I can give to you is make sure you have a cluster of questions in your head for the consultation stations. And what else can I tell you? Make sure that you finish your neuro stations early, 5 minutes and 30 seconds, please. And yeah, just remember you do have a piece of paper to write down stuff on for the consultation specifically. Well, you have them for all stations, but I think they're useful in the consultations. I'm just going to quickly show you the results sheet that I get. 1 minute, please. MRCP exam. There we are. There. Where am I going with this? There. No. Oh, here. Cool. How big is it's just how big is the paper, and is there a clipboard? You get a pen or a pencil. You get a pencil and it's an A4 sized paper. It's plain with no lines. You don't get a clipboard, unfortunately, because you have a clipboard with your mark sheets that you then hand over to the examiner for each station. So you just get a piece of paper lying around and just a pencil next to it. You write stuff down. I don't think it has an eraser with it. You also get a cup of, or whatever, glass of water next to the in the 5 minute breaks that you have in the tables there. Results. Let's look at the results. Okay, so this is it. This is the one that tells me that I failed, I think. We are sorry to inform you that you have been unsuccessful. Boo-hoo. So this was it. I'm going to try and explain how you get marked. Whoops, sorry. No, I'm going to zoom out a bit. Sorry. Yeah, that's good enough. Hopefully you can all see this right. Can you? Yeah, I think you can. Right. So if you can look at the top half gives you the marks that you get for each station, right? So for communication one, I get 16 out of 16. For respiratory, I mess it up and I get 12 out of 20 for consultations. So that's how you get marks on for the stations. But the actual marking is here because you get marked according to each skill or each domain, and you have to pass each domain. Now, if you look at all the way here on the right-hand side, the total score required is 126. What did I get? 130. So I thought I passed, but actually, if you go down all the way here to clinical communications, I got a total score of 10 out of 16, and the pass mark was 11. And so I failed clinical communications, and hence I failed the whole exam. So that's how you get marked for PACES. In my second attempt, I got a bit more than 126. Sorry, a bit more than 130. I got 135, and hence that was good enough. Yeah, you're right. So I'm sure you've looked at the mark sheets for each individual station. Not every domain is marked on across all of the stations that you get. I can't remember which ones, but I think like Uruj mentioned, clinical comms is not marked on the examinations because again, you're not really communicating with the patient. And even if you felt you did not do well on the exams, it was actually the consultations and comms that brought you down. Exactly. So on my first attempt, I thought I messed up the respiratory and the neuro exam and I'm going to fail. When I got the result, I thought, 130, that's above the passing mark. I didn't get enough marks on my consultation stations, even though I thought I did pretty good. But what I realized with consultations was I didn't have a structured cluster of questions to ask and blurt out to every patient. Um, I think having a cluster doesn't, I think it also helps because then you've made sure that you've got all the information from the patient. And also you probably notice that one domain is also kind of linked to the other domain too. So if you're not really getting the diagnosis right, then you can't get the clinical judgment part right. And that means that you're losing points in more than one domain because you made one mistake. Can you give us examples for cluster of questions? I certainly can. If you still have a few seconds, I can quickly show you a file that I have. Which has a very nicely set up cluster. 1 second. And I'll share the file on, I don't know if I can upload it on Zoom or not, but I'll check. 1 second. Where was it? Listing pieces. Thing was here. Aha, here it is. In share. So this is what I'm talking about. Again, you don't have to copy it from this folder. You can make your own as you like. I can start from somewhere useful. So let's look at this. So here you've got all the questions you need to ask for a central nervous system scenario. Similarly, you've got another one for GIT. So if there's a gastro case, these are the questions that you can ask in gastro. If it's a respiratory presenting complaint, these are the questions that you can ask for respiratory, and so forth. It's I think it's quite a useful file, especially if you're too lazy to make your own. I don't know if it's worth sharing it to you guys. Would that be something you'd be interested in? I'm not sure. Let me know. Yes, okay. Yes, please. I've got two. There's a question by Paul. Yeah, I'll share it. That's okay, it's fine. I'll share it. That would be great. Indeed. I just missed a question. The management of high output stoma, is it loperamide? Anything else? So because it was Crohn's disease, I think the management that I was focusing on was more on uh actually, it was more about the electrolyte imbalances. And the thing is, when you're talking about management, what they tend to do is they try to stop you in the middle and then add another question to it. So in my case, when I said that, oh, if this person has a hypostoma, we'll take a sample of the stool, we'll send it for this, and if they come back non-infective, we can start them on loperamide. I look at his blood test. For blood tests, I'll be looking at electrolytes. And as soon as I mentioned electrolytes, they said, which electrolytes do you think would be deranged in a case of high output stoma? And then I said, I don't know what I said. I think I said sodium levels, and then they asked me if would there any other are there any other electrolytes that could be deranged? And I think I said potassium or magnesium. I made something up. I wasn't sure, but I still got good marks for it, so I don't know. Must have been fine. What did you do between your first and second attempts in order to pass, Olivia? So, like I mentioned, cluster of questions. I'll share the folder. That was really useful. Um, I still now, oops, I joined 10 minutes late and missed the slides before cardiology. Can you talk about them again? I can talk about it in a while, in a little bit, Juruj. Any tips for beginners? This is being recorded and shared. It's okay. I think it is being recorded, yes. So you can ask Joey for it. Going back to Olivia, cluster of questions. I still to this day don't know how to prepare for consultation stations. I used my brother as a patient and I made him role play as a patient to try and help, but I don't think it worked out too well. It was hard to find an actual patient in the hospital and sit with them and make them do this. Didn't do that either. So all I think really helped was just going through the there is have you guys heard of the Aid to MRCP? It's a book which has a section on um, clinical consultations, and it has about 60 role play scenarios. So if you've got someone with you who you can ask to role play, maybe that can help. I'm still not convinced that it helps a lot, but at least you can have an idea of how things work. Try using ChatGPT voice option. I don't know. I didn't do that. Could help, I suppose. So yeah, the only difference second time around was I was prepared for the consultations with the clusters of questions in my head, and I was less nervous because I knew what to expect. I was prepared to finish my neuro in 5 minutes, 30 seconds, and I think that's the only difference between the first and second attempts. And to be honest, the first attempt I got 130 out of 168. The second one was 135 out of 168. So again, not a huge improvement to begin with, but it was enough to just get me to the other side. I'll see. Also, I think I had some more questions earlier. Can you share the questions you got on the second attempt? Sure. I can talk about them if that helps. I don't know if you would enjoy that. 1 second. Just checking what other questions were there. When should we do the systemic review? Do we need to do it at the end of history taking, or can we ask after taking the presenting complaints? So Nazia, I think you're asking about the consultation stations here. I do them after the end of history taking personally, but people do it differently depending on whatever they're comfortable with. And So let's say in my case, if I finish history taking and then I do my systemic examinations, I can still ask them to come back and sit down, and I can still ask them further questions. No one's going to stop me from asking the questions, and I won't get marked down for going back and asking questions again. That does not happen in PACES at all. You can be the boss of how you want to lead for those, uh, I don't know how many minutes they are. I think is it 14 minutes or something? So it's up to you how you want to lead them. I think it's easier to do it after history taking because then you would know what systems to focus your examination on. So sometimes the presenting complaint could be very vague, so you're not really sure what to examine with just the presenting complaint. So once you had a full history, you might be able to narrow down what you want to examine. And I think then your examination would also look more smooth. Runs through the slides for a minute. I can run through the slides, sure. I don't know, like, sure, I can run through the slides. While I'm running through the slides, I'll also talk about my second exams cases because I'm sure some of you would love to know that. Okay, I'll turn the slideshow on for this. Um, so I'll talk about the second exam. So for the second one, what do I talk about? I started with station 3 again for my second one. And the cardiology station was quite interesting. It was the faintest aortic stenosis murmur I've ever heard in my life. Um, I all the way till auscultation, I heard nothing, and I thought, oh, as when I say nothing, I mean like I didn't hear anything wrong with the lady, and I was like, whoa, it's a cardiology station. I finished listening to the heart, and I still don't know what this case is. And then, luckily enough, before the panic set in, when I heard the carotids, and I did hear a faint radiation, and I thought, okay, hold on a second. I went back to listen to the aortic area again, and I thought, oh, okay, maybe there is a murmur there. And oh, it is radiating to the carotids. And turns out it was a case of very severe aortic stenosis. Well, the most severe I've ever heard in my life. So yeah, that's what I got from my cardiology station. Sorry. And again, I might be confusing you with what I'm showing you. Never mind. I'll talk about the second exam first, and then I'll run to the slides later. In the neuro station for the second exam, it was still very hard. It was a guy um, who I had to examine lower limbs on, and he had upper motor neuron signs on both legs, but then he also had this. His left hand was just twitching for no reason. And I was like, oh, what the hell's going on? I've been asked to do a lower limb exam. This guy's got upper motor neuron signs and legs. And I thought, okay, you know what? I'll just ignore the hand. And in my presentation, I said, this man has upper motor neuron signs of the legs. These are my differentials, blah, 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 blah. And then the examiners asked, how do you link the finding on his hand with his legs? And I was like, oh. And I just said, it could be Parkinson's. And that's all that happened. Then they asked me about the management, and I talked about management for Parkinson's. I talked about management for upper motor neuron disease. Um, it was a bit crazy. And looking back, I'm still not sure what the diagnosis was for neurology. That's the truth. And what did I get for my? I should open the chat in case I'm missing anything. Yeah, what did I get for my abdominal case? It was a straightforward case of someone with diabetic nephropathy with a renal transplant. You need to be very like on it with renal transplant. If you get a renal transplant case, you need to know how to present that case. You need to, I'm sure BitePACES and Shoaib's done a great job telling you how to do it already. But things like is the transplant working? Were there any previous signs of renal replacement therapy? Any signs of, the tunnel line here or fistulas in the arms? What could be the cause? Top three causes, complications of renal transplant. Um, so things like immunosuppression side effects, immunosuppressive therapy side effects, steroid side effects. You need to know that like on the tips of your fingers, and also because it's not something that you normally memorize or learn about on a day-to-day basis, unless you've done a renal rotation. What did I get for respiratory? It was a straightforward case of COPD. This time somebody had inhalers with them, and that's all there was really. I didn't find anything else very exciting about them. What did I get for my consultations? So I mentioned one of them already. One was a guy presenting with a fall from a few weeks ago, and he just coming in because his wife forced him to come in to see us. And it was quite similar to the other consultation I had with my first exam, where there was nothing wrong with him whatsoever, apart from the fact that he just had this one fall. He was a fit guy in his 60s. But then when I finally asked him, do you have a racing heart? And he said, oh yeah, I do get a racing heart sometimes. And turns out it was paroxysmal AF and um, cardiac syncope. And so my differentials, well, my management was basically trying to catch the AF with things like a 24-hour tape or a loop recorder, blah, blah, blah. The other consultation was a case of cerebral venous sinus thrombosis. Oh, I think I messed that up pretty much. Um, the only thing that I had to go on was the fact that she was a 20-something-year-old girl with um and the only thing on her history was the fact that she took a oral contraceptive pill. That was it. She had a headache last night. That's all it was. So all of my questions and all my examinations and everything were just pretty much useless. And if you know that someone who's young and takes the pill and has a headache from an acute onset headache, this all could relate to cerebral venous sinus thrombosis, then you can ace that station. If you don't know that bit of information, then you might be struggling a little bit. Um, the comm stations were again very easy. I can't even remember what they were because they were really that easy. One was about a medical error. A nurse accidentally gave the wrong patient morphine, and now they're complaining about having morphine, and they've had someone from their family who died after taking morphine. So just a case of a medical error. And the other communication station was peg feeding. So someone with Parkinson's, and the wife was wondering why she couldn't be peg fed. Communication in the consultation stations must be top notch despite not reaching the diagnosis. Yes, maybe. Perhaps so. I can show you, I don't know, I don't know how much time you guys have. You're still online, that's pretty good. Even though it's well beyond 8 o'clock. Let me see if I can at least share the file for the, what do you call them? The clusters, cluster of questions. I think I can if I just drag and drop them here. Does that work? Aha, hosts and panelists. No, I need to send it to everyone. I'll do that again. Can you all see the file that I've just sent you? That's the one that has the clusters. You could maybe make your own clusters by taking some inspiration from this file. I think that'd be a better way to do it. I didn't make that file. Someone sent it to me. Don't know, it was just a friend, and I thought it was useful. Uh, no file yet. If you go on chat, I think you should be able to find it. It's on the webinar chat. One of you, I think Teen has already replied. that she can see it. No files. How come? No file. Okay, yikes. Let's try that again then. Okay, okay, got it. Sorry. I'm pretty sure. Yes, it is there. You can share it on WhatsApp group. Can see it, but unable to download it. Fine. I'll ask Shoaib to add me into that WhatsApp group again because as soon as I passed my exam, I left that group. So once I'm back in, I can send you the file in there. But it should be on the webinar chat. I made sure that I clicked on send to everyone and I sent it through. When do you ask the cluster of questions? At what point in the history? Um, mm, I did it after pretty much after my history taking, after I completed all the history taking possible with the family history, social history, blah blah blah. And just before I went into the examination sequence, I just tried to remember if there's anything that I still have to ask from those cluster of questions. And I said that okay, um, I'm just going to examine you shortly, but before that, can I just check if you've got this, or whether you've got a racing heart, or whether you've got blah blah blah. Yeah, I can try sending one again, sorry. So that's how you can fit that in. And again, it really doesn't matter where you want to fit it in, as long as you're comfortable with it. I've sent it again. I don't know if it's because you're on your mobile. I'll send it on the group as well. Don't worry. I did. I literally sent it to everyone rather than host and panelists. I'll try again. I think instead of dragging and dropping, I'll go and try and do it this way. I can see and download it. Thanks. Okay, good. Guys, it's on the laptop or the computer. Sorry. Um, by the way, Magdalene, I think you're messaging to host and panelists only. So just message to everyone. Um, is there anything else I can do for you? Are you still in the mood to look at my, yeah, sorry, OT, you have to I'll send it on WhatsApp so you can download it on your phones. Um, are you still in the mood to look at my feedback for the second exam? Is that useful, or do you want to look at the results of my second exam, or have you had enough? It's entirely up to you. Um, and actually, if there's anyone who wants to leave, you're more than welcome. Thank you for joining us, and I think BitePACES was a really nice course. It was a 4-day course when I attended. Um, I think it's even better that they're squeezing it in 3 days. Pretty good. Sure. Group link. I'll send it on WhatsApp, Ashok. And okay, let's have a look at the feedback. I didn't think you'd be that interested, man. Okay. Let me just quickly send it to I think it's on my emails. Oh, you want the link to the group? You don't have the link to the group either. Okay. Just hold fire, Ashok. We'll sort you out soon. It'll take me one more minute to find it for you. The feedback. Mm-hmm. I think just send it to me. So this is the one that I passed, right? Yeah. Okay. Email that to myself. Okay, let's have a look at the results for the exam that I passed. And then I'll show you the feedback too. I think that's more interesting. But yeah. What are you screen sharing at the moment? Okay. Instead of this, can you, is this the one? Thanks. Hey, that's the one. Can you all see the right one? Is this the one that that says I've passed? I'm not even sure. Is this the one that says I'm passed? Yeah, good. So we congratulate you on your success, blah blah blah. Let's look at the scores here. So this time round, I've got 135 instead of 130. And I think I failed in clinical communications last time with a score of 10 out of 16. This time I got 13. And to tell you, I think my consultations, the second consultation went pretty well, 26 out of 28. Well done. The first consultation was still mediocre. Looks like one of my communication stations went poorly, and I messed up the neurology exam. See, it just happens every time. I can't stop, no matter what I do. Um, so yeah, abdominal went well, respiratory went well, cardiovascular went okay, neuro went badly. And I think something I didn't expect was my comm station going a bit poorly. It just goes to show that it doesn't really matter what you think, how you think you've done after the exam. They could mark you, they can mark you down on something that you weren't expecting to get marked down on. Do both examiners mark you separately and they take an average? No, so the way it works is you get two examiners in each station. They do their own marking, and then you add up all the marks for all the examiners that have assessed you. So there's no averaging in each station. So one examiner might mark you more than the other, but they total those marks. But in many cases, you'll find that the examiners mark you similarly because they're assessing you for the same station, right? I'll try and quickly show you my feedback too. I remember requesting it just because I like looking at things and feedbacks. Sorry, 1 second. I know some of you have left already, but I'll try and squeeze this into. Am I going to? Oh, there it is. Yeah, found it. Oh, candidate feedback. Candidate feedback. Okay, got it. Candidate feedback. There we are. Inbox. Aha, there it is. That the one? Yeah, that's the one. Isn't it? Yeah. Time to open this properly. I don't know why screen sharing is paused, whatever. But let's show this. So this is what a normal mark sheet looks like. So as you can see on this side here, this is for station 1 communication. This is the mark sheet that is given to you before the start of the exam. And this is the boring bit that you have to sit down and write yourself, actually just up till here. So you write down the code number, the examination number, and the center number, and you mark it 16 times for 16 mark sheets that you get. So imagine it takes about 20, 30 minutes. Um, so yeah, I don't know. I can go through this. This is a com station for palliative care. This is the one that I didn't get good marks on. Oh, I got one new message. Sorry. Every domain is scored from 2 by each examiner. 2 is full, 1 is borderline, 0 is fail for each domain. So the thing that determines if you pass or not is whether you have failed any of the skills from the cumulative marks from all the stations. Is it Elena? I can't see your full name, but Elena, you are correct in assuming that. That is exactly how a pass or a fail works. Sorry, just quickly checked the questions, but this was for my com station palliative care. Satisfactory in the clinical communications. Judgment was poor. I was not very clear that the condition is end stage and patient is for palliation. It was some guy with Parkinson's who was not eating and drinking well, and the wife said she wanted the peg tube. I just told her peg tube is not always a good idea. I can have infections, blah blah blah, and the patient might well be coming towards the natural course or end of their life. But I didn't go too much into end of life. I just said we won't have the peg tube, and so I didn't get marked well on it. Although tried to reassure the wife, but was not very clear of the goal of treatment. Don't know what to say. Here again, I got borderline and borderline. So as you can, in this particular one, you can see that the first examiner gave me 0 marks. The second examiner gave me 1 mark, thankfully. Does not blah 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 consider the palliative care as the whatever way forward, appropriate way forward. Does not consider involving palliative care team. Yeah, that's true. I didn't. Mm-hmm. Yeah, the second one, this was pulmonary fibrosis. Again, good marks on here. Mentioned COPD as first differential. I think I'm just rubbish in respiratory altogether. But yeah, did not consider ILD as top diagnosis. Then this was the consultation. This is the guy who collapsed because of cardiac syncope. Um, Pretty much borderline all throughout the the station. Explaining AF is not appropriate. Missed family history. That's true. I missed family history on the guy who had a cardiac syncope, and I couldn't go towards Brugada syndrome. That was my fault. That happens. Needs prompting for longer monitoring. So they asked me how would you diagnose paroxysmal AF, and I said ECG, and then they said what else? I said they said what if the ECG is normal? I said you could do a 24-hour tape, and then they said what if that's normal? I said 72-hour tape, and then they said what if that's normal? I said a week's tape, and then they said what if that's normal? And then I said a loop recorder, and the station finished by them saying, don't you think that's a bit invasive? And the bell rang. I was like, oh, I was in the rush of just moving on to the next station. So similarly here, you can see there's a difference between how each examiner marks you. Yeah, it's true. It just happens. This was the very faint aortic stenosis. Now here, I got marked down for not listening to the lung bases. I normally do not listen to the lung bases in a cardiovascular exam. I accept that blame. I didn't even know that I'm always supposed to be honest. But yeah. So maybe just listen to the lungs. And so I missed by basal crept as a result. Missed chest exam. Yeah. And then what's this? Oh yeah. So apparently this was Parkinson's disease. Whoa, see? So the neuro exam with the hand tremor and the upper motor neuron signs of the legs. I even made him walk. I couldn't notice his, the thing with the shuffling gait or the reduced arm swing. I didn't notice that a lot. I just thought it could be Parkinson's. And I've messed the whole station up. I don't even want to talk about how it went. Um, yeah, it was just bad throughout. Sorry, I'm not really being very helpful with this one because oh, here we are. This is a comm station about the drug error. Someone was given morphine by accident. So you apologize, talk about date text, reassure them, explain about side effects. Follow a protocol. With comm stations, just follow a protocol. Yeah, full marks in the other by the other examiner. Renal transplant, again, if you get a renal transplant and you don't get full marks, then you are to blame. Yeah, again, this is the second examiner with renal transplant, full marks. And this is the other consultation. This is the girl with the headache who had cerebral venous sinus thrombosis. Crazy diagnosis. Um, I'll be very honest with you. In this station, I think the examiner helped us a lot with prompting us towards the diagnosis. And I noticed that with the other candidates as well. Because after the exam, we all spoke about this station and they said that we weren't sure. And we all agreed that the examiner was actually being very helpful, pointing us towards the right direction. So I honestly thought I did really poorly with this one, and I still somehow got full marks by one examiner, and the other one gave me some borderline marks for the other. Phew. That was it. Some people tend to write a lot in the feedback, don't they? And the other people just kind of leave it fairly blank as well. Yeah. So and that's just subjective. Depends on how people do it. Is there a list of comm station protocols just to ease revision? I don't think there is a list. The only mnemonic I remember is spikes. I'm sure there were a few others from a few years ago, but I can't think of any right now. Um, check the WhatsApp group. Maybe they might come up. You guys might come up with some nice protocols too. Um, no problem. Thank you for attending and best of luck with your exam. I hope it was useful. And yeah, definitely check out BitePACES if you haven't already. They're a good bunch of people, quite helpful. Off to revise trochlear palsy. Yes, please. Definitely. What would be your last moment tips for the exam when you have less than a week's time? Um, Less than a week's time, finish off making sure that your examination timings are top notch in the next couple days. And then when you have like 3 or 4 days left, do all the memorizing bits with the DVLA guidelines, um, treatment or management for stroke, management for ACS, the things that you really have to memorize, knowing about therapeutic windows and stuff. And then um, last day, I would just recommend going through the clusters for the questions for the consultation stations, and that's about it. Can you send the clusters? Yes, I will send it. You're welcome, me now. Do you have a list of consultation cases that could appear in the exam? Um, I don't have a list of consultation cases, but I can tell you a book. I'll write it down here. It's called An Aid to the MRCP. There's a part in here called Section H, and they have like 60 odd scenarios with proper role play instructions. So just go through those, and I think that's the best that you can do for consults. We got more signs by doing upper limb exam to make diagnosis of Parkinson's. In that case, when we are asked to do a lower limb, are we supposed to do a quick upper limb quick exam? Oh, I've always expected Parkinson's in an upper limb or a cranial nerve exam as well. I never expected it in a lower limb exam. Um, I don't think the examiners would have wanted you to do a full upper limb exam, but just if you could just mention it to them that you've noticed a resting tremor, that's good enough. Because with a lower limb exam, you just can't fit in anything else. I ran through my exam for the lower limb and I finished bang on when the patient walked back to his seat and sat down. That's when I finished. That was the last thing on the list of my lower limb exam to do, and I just finished on that second. So there was nothing else that I could do apart from just the lower limb. And then remember, you were getting marked on your physical examination as well. So if you're being asked to do a lower limb exam, make sure you complete the lower limb exam first before going on doing other stuff. Yeah, exactly. Uruj mentioned that you would want to do an upper limb exam. I mentioned that as well. I said I'd like to do a full upper limb exam, a full cranial nerve exam before I find out what's to help rule out diagnosis. Always say that in neuro helps. And I'll send the cluster of questions on the WhatsApp group again. Sorry. Can I say, yeah, you could. Oh, I mentioned that already. I think that's it. Thank you so much for attending, you all. No problem. Thanks, Bo. You're welcome, Ati. See you. You're welcome, everyone. Good luck with your exam. And yeah, hope we don't have to attend this meeting ever again.